thought we were definitely cousins. I know it was probable. That's all right. That's cool. Nice to meet you all. Thank you all for being part of this project. So I'm going to try to give an overview of coronary heart disease over the next hour. Sorry, actually not just coronary heart disease. That's one type. I'll be talking about the various kinds of heart disease and talk about some of the things that we need to think about and worry about in terms of symptoms and in terms of the basic aspects of the management for people with heart disease. So there'll be a couple of areas for questions, but I'm gonna really encourage folks to stop me and ask questions as we proceed through so we can make sure that we're as clear as possible. So in terms of who I am, so that's me. I have a couple of different roles. Yeah, thank you. So I am an attending physician in the intensive care unit for cardiology, so the coronary care unit at Johns Hopkins. So on one role, I kind of deal with people who come in with extreme kinds of, so heart attacks, really bad arrhythmias, severe heart failure. But at the same time, I also deal with the prevention side. So I'm in the clinic, and I'm in what's called the Chiadi Center for the Prevention of Heart Disease. I think Seth Martin spoke with you all about cholesterol, and he is a part of that same center as well. So I kind of work on both sides, trying to help prevent and also trying to help treat when it gets to that point also. So the objectives about this, for this talk, first of all, we're going to learn about the different forms of heart disease and kind of go over some of the basic aspects of those. And then number two, we're going to try to make sure we have a good understanding of the risk factors for developing heart disease in the first place. And a lot of those risk factors, how well we manage those, make a difference for how people have their outcomes in terms of heart disease. So the worse control of risk factors, most of the time the worse outcomes for people who have heart disease. And then also we're going to talk about some of the basic strategies for managing heart disease. And the goal is not obviously for everybody to be a cardiologist, but just to have a general sense of some of the kind of core things that we should do to get started for people who have heart disease. Just to give you a sense of how this fits into my role with this project. So for the specialist corps that individuals being referred to, I'm going to be the cardiologist within the specialist corps for this project. So I have a couple of questions first. So how many of you all have had to support family members or friends who've had heart disease? Yeah? Can you tell me a little bit about that? Have they relied on you to ask questions about the medical aspect of it? Have they been concerned about how they were going to do in terms of living?
Well, I have a husband with atrial fib, and
Yeah.
he has a pacemaker, 4 stents. So we've been through a good bit with him since he was about 28 years old.
28 when it started. We'll talk a little bit about that, but that's obviously an early age for that. And you know, that's actually so one of the things that's very important within this project is providing the support for individuals in terms of managing disease, and self-management is actually a very big part, as I'm sure you know, of heart disease. And what we find often, for example, there's a lot of data out there that people who are married, especially men, particularly who are married, they do much better because they have the support and they help with their medications and with appointments and a whole bunch of other stuff. So you can see, I'm sure you've seen that, you can see the important role of support in helping to manage somebody who has heart disease. How about your experience?
Well, mine is my own.
Okay.
I have PVCs, which the doctor said is normal. Everybody has them, but certain things that you do to prevent them. But in my mind, I have to keep telling myself, oh, you can't have that drink, but you can just have that one drink. Go ahead, you ain't gonna have no PVCs today. Or definitely, I'm not supposed to be having this.
This Diet Coke with caffeine?
This is regular
Coke, sorry, yeah.
Very seldom don't drink Coca-Cola, Sprite. And stuff like that, I have to be mindful of my diet.
Yeah. Well, see, that's another very important point. So you brought up several things. First of all, it's understanding what the condition is and what's serious and what's not serious, right? So you talked about something about benign, right? So knowing what things are life-threatening and not life-threatening, but then also knowing what things make a difference for how you're going to get symptoms. So you know that caffeine affects your PVCs, but you know, the knowledge of that is a very important thing in terms of how you deal with that. Go ahead.
And also, I know I have to be well hydrated, because
Yeah.
if I'm dehydrated, oh, the PVCs is on.
Yeah, so this is very important. And individuals are different, but at the end of the day, these things are still at the core of cardiac disease. So understanding the condition, knowing what's important in terms of self-management, understanding why you're taking certain medications or doing certain dietary things, going to your appointments and having that adherence thing, all of these things make a really big difference in how people do with heart disease. So not only are there different types of heart disease, but the spectrum of heart disease, the risk really relates to how people manage that in all these different aspects. So these are kind of the roles I think that you all are going to be playing in this project. So I think that's very important, all these aspects of support. Strategies that you've used in the past to help care for patients with heart disease? Have any of you guys used strategies in your kind of clinical work at all, or in any other involvement with people with heart disease? Getting people to take their medications, getting people to go to their doctor's appointments? You can talk from your perspective in terms of the strategies you use on yourself.
You mean, focusing on constantly talking to myself
Mhm.
about what I need to eat, what I can't eat, what I can drink and what I can't drink. Because every now and then you like to have a nice little stiff little drink on the rocks, you know. But you also know that if you go overboard with it, you're going to pay for it later.
So it's constantly kind of talking to yourself, educating yourself, reinforcing, and not just a one-time thing, but it's an ongoing thing. And I think that's a process that's the case for everybody. It's not just, hey, I heard this one time and I'm good. It's sometimes you need to reinforce, sometimes it has to go in different ways, and it's also individual. Some people like more than one drink of alcohol. Some people don't drink alcohol at all, so the same recommendations are not going to be the same for everybody. It has to sometimes be tailored to who somebody is and what their lifestyle is. So these are all things I think are very important themes. So we'll kind of hopefully revisit some of these things as we go through. Sorry. Okay. Somebody's calling in for?
To hear you.
Oh, to hear, okay. Should I pause or keep going?
Keep going.
Okay.
Sorry.
No problem. So, first question is, what is actually heart disease? So everybody, I'm sure is familiar with this. That's the heart right there, right? And what's the primary thing the heart does? Anybody?
Pumps blood.
That's what it does.
Oxygenated blood.
Exactly. So hopefully oxygenated blood. Yes, exactly. So oxygenated blood, so blood that has oxygen, and it's giving it to all your vital organs. The big ones are your brain, your kidneys, but every place in the body that has to function needs oxygen to be able to do that. And that's what the heart does. Now, in order for the heart to do this, a couple things have to be going right? So first of all, number one, it needs a fuel supply, right? So the heart is a muscle, it's pumping away, but it needs some blood and oxygen itself to do what it has to do. So that's the first thing. This open blood vessels, since the blood vessels that give that oxygenated blood to the heart itself, those need to be nice and open. If those aren't open, then the heart's not going to be able to do its pumping job, okay? Second thing is the heart needs to be able to pump and relax. So some of that's related to the open blood vessels. Sometimes there's other issues with the heart muscle that doesn't let it either pump blood well or it doesn't let it relax. So you need to relax. It's like a balloon, okay? So if you have a balloon, if you can imagine blowing into the balloon, right? The heart fills up with that balloon and then needs to push the air back out. But if you have those stiff balloons sometimes where you're like working really hard to blow it open, that's what happens sometimes we have a really stiff heart that can't actually fill up with blood. So that could be a problem too. So either not filling up or not being able to pump. Both of those are problems with the heart, okay? Also, it needs a normal rhythm. If the heart has a really abnormal rhythm, like for example, let's say it's going too fast, it doesn't have time to fill up with blood. It's like trying to blow that air into the balloon in 1 second. It needs to have time to blow up, let the blood out. So that's what it needs to do, and if it doesn't have enough time with a normal rhythm, that's a problem. And then you also need functioning valves. The valves are basically within the heart. They let the blood go forward, and then the valves close so the blood doesn't go backwards. So it has to open well and not let blood leak back in the wrong direction. So all of these things can lead to problems with heart disease, okay? Problems on any of these areas can be issues that basically cause what we call abnormal heart function and cause heart disease. So it's important to realize heart disease isn't just one thing, but it's any of these things that get in the way of this nice normal function of the heart. Does that make sense? Okay. So let's talk about the different types of heart disease, and I'm just going to go through a list, and I'll explain some of the most common ones. So the first one that you hear about a lot, who's heard about coronary heart disease? Everyone heard about that? Okay, so coronary heart disease, really, there's a couple of ones. We'll talk about it in more detail, but angina is when the coronary heart disease is causing chest pain, and we'll talk about that more. Myocardial infarction, the other term for that, anybody? Heart attack, right? So that's what we hear on TV as a heart attack. So those are the two big forms of coronary heart disease. Congestive heart failure, so this is a fancy term here. Congestive heart failure is basically when you have problems with either that pumping or that relaxing of the heart muscle, okay? When you have problems with the pumping, the ejection fraction basically is when the heart fills up, how much of that blood is pumped out to the body, okay? If 55% is pretty normal. So if you have a normal ejection fraction, we call that heart failure with a preserved ejection fraction, where it's usually very stiff and blood starts backing up into the lungs because of that. Reduced ejection fraction is where the heart doesn't pump very well. So it doesn't pump blood forward, and that causes a problem with congestive heart failure. So there's two different ways, but they're both very important and they're both risky. Heart arrhythmias, so abnormal heart rhythms can happen either the top part of the heart, what we call the atria, or the bottom part of the heart called the ventricles. PVCs, as you said, are a benign form, but the ones we're concerned about, atrial fibrillation is one, like you just mentioned. And then ventricular rhythms like ventricular tachycardia is another big one, where you have abnormal rhythms. This is atrial fibrillation. Anybody know why this is particularly important? Atrial fibrillation, because it can cause what? Anybody? Clots, exactly. Because the atria needs to kind of work like this, and if the atria is doing this, then you can basically build up some blood clots in there that can cause strokes. So atrial fibrillation, that's the biggest concern from that. On the other hand, ventricular tachycardia is actually life-threatening. So that's not PVCs, but ventricular tachycardia, where you have an abnormal rhythm in the bottom part of the heart, that can go really fast, and those are the things that people can collapse from. Go ahead.
That's just like my mom, she had what they call the bypass tract
Mm-hmm.
in her heart, where the first time it was discovered, her heart rate went up to like 208.
Mm-hmm. Mm-hmm.
And they wanted to do the surgery. She said no. Every now and then it get a little fast, but this past January it was like 183. And just in a little small fraction of that time from that heart beating fast and not able to do what it needed to do, they told me that my mom had a minor heart attack in between that time.
Yeah, so that's right. So sometimes, because what happens is, if your heart's going really, really fast and it can't fill up with blood, you can actually not pump blood forward because it's not filling, it's not getting anything in it. And that can actually lead to some of that heart muscle getting damaged. So that can happen. So it's actually something that, those are one of those life-threatening kind of conditions, the ventricular tachycardia. Your mom has what we call, it's similar, it's a variant of that, but it's important as well.
And also, depending on if she drank something with acid in it.
Yeah, that can cause more problems for her.
Yeah.
I'm very sorry to hear that. Yeah, but that's a real thing, and we can talk more about that, but that's important. The valve issues with the heart are also important. So we talked about either the valves cannot open all the way to let blood go through. That's called stenosis, where they're too stiff, or they can leak. That's called regurgitation. Okay, and then strokes and problems with the vessels in the brain. They're not quite the heart, but because they're part of the blood vessels, they're considered a form of what we call cardiovascular disease, which is the broader heart and blood vessels. So that's often considered in there as well. And then there's another category that you probably won't be seeing very much of called congenital heart disease. People who are born with heart defects. A lot of times those are fixed when they're young, but because we're getting better at that, people are living much longer. So 40, 50, 60-year-olds who are having histories of congenital heart disease, okay? So those are the kind of most common types of heart disease that we'll be thinking about. So why is heart disease important? So number one, this is a graph showing the leading causes of death in the United States. And A for men in the dark blue, and A for women in the light blue is heart disease, okay? So you can see that that's still the leading cause for everything. Cancer is number two. So the leading cause of death, it makes it a very important issue for us to focus on in terms of helping our patients with. Yes?
What is the correlation between women and heart attacks or heart disease, because they have more of a higher risk of having it than males?
So the issue with men and women, so that's a very important point. So both women and men, it's the leading cause of death, okay? And a lot of women don't appreciate the fact that heart disease is the leading cause of death. Now, at a younger age, so when you're 50s, 60s, and 70s, men are going to be more likely to develop heart disease than women. Just if you compare who's developing it at the rate. The reason women still have a lot of heart disease is because they live longer. And as they live longer, they're often getting heart disease at later ages. I'm sorry, I should probably begin this microphone. So they're getting heart disease at later ages. So overall, even though women tend to get it a little bit later, it's still the leading cause of death for both men and women. Does that make sense?
But why is it higher for women?
This is, it's not that, it's more that basically, this is, I think this reflects basically the fact that at later ages, most of the women are dying from heart disease at later ages. But overall, it's similar and it evens out, and that the most important thing is that they're both the top, basically.
Can you say that women live longer and die later?
Correct.
Than men?
So we know that already. So women have,
die earlier.
correct. So we know that women live a bit longer, and we also know that when they develop their heart disease, they're developing a bit later, basically. But an important message so there's two things about that are important. Heart disease is not something that just starts at age 70 or age 60 or 50.
Right.
Heart disease starts when you're young.
Right.
And actually, they did actual autopsies of people from the Vietnam War back in the 70s and found evidence of early heart disease in the 20-year-olds who were coming back on their autopsies. So that's when we discovered that it's actually a process that starts very early. So doing the things that we're going to talk about in terms of controlling risk factors are important regardless. Even though women are going to develop it later, the things they do early in life have a very big impact on whether or not they develop heart disease later in life. Yes, ma'am?
Big of a factor is family history.
So family history is important, and that's one of the things we'll talk about in terms of the risk factors. The important thing to say about family history is if you have a strong family history, and we'll talk about what that means, it does increase your risk, but most of the time, there are things we can do to manage that risk. So I see people in my preventive clinic who are very interested in prevention because they have a family history. And we can often identify the things that, like for example, the most common thing is abnormal cholesterol. We identify that early, deal with it early, they can have a very different history from other people in their family. So it is important, but it's something that we can most often deal with. Does that make sense? Okay. All right. So in terms of the types of heart disease, so other things we talked about, coronary heart disease that causes the heart attacks and the angina, that's the most common cause of death, followed by strokes and heart failure. And then you'll see the other kinds of things. High blood pressure is often put in the heart disease category. I don't strictly often put it there, but because it's a problem with the vessels, we often think about that there. But the big things are coronary heart disease followed by stroke and heart failure in terms of causes of death among people with heart failure. The other thing to be aware of is that there are pretty significant racial disparities in rates of heart disease as well. So in this, this is looking at, in the blue versus the red is black men versus white men. The light blue versus is that pink or white? Yellow. Sorry. The light blue versus the yellow is black women versus white women. And you generally see that there are higher rates among African Americans compared to white Americans for different kinds of heart disease. We've also seen this for Hispanic Americans as well. So that is a very common thing. It's for multiple reasons. A lot of it has to do with risk factor control and the self-management issues that we'll be talking about. So, and there's other issues as well, but it's a very complex issue. Coronary heart disease, the one good thing is that the rates are actually getting better. So this is looking at what's happened over time. So you can see that around 1960s, 1970, we started seeing a decline in the rates of heart disease. A lot of people were having heart attacks. People from all stripes are having heart attacks, but we've seen that as we've done a better job of controlling risk factors and also doing a better job of treating people who come in with heart attacks and strokes, that we're basically seeing improvements over time in these. So this just shows the power of actually getting those proven therapies and proven behaviors in place that can actually make a big difference on whether or not people actually die from heart disease. Okay? So now we're going to go over some of the specific kinds of heart disease. So I'm going to first talk about coronary heart disease. Okay? So what is coronary heart disease? Okay, so this here is the heart. If I step away, can I still hear me okay? Okay, okay. So this here is the heart, and you can see here, this is the main blood vessel that comes off the heart called the aorta, okay? That's the buildup of fatty materials, or we call plaque, based on buildup with mostly cholesterol, in the walls of the arteries that's where our problems start, okay? First, you can get partial blockages of the arteries. So if you get arteries that are somewhat blocked, they can actually lead to some heart dysfunction. So let me just show you that here. So this is an artery. The artery is kind of a tube, and you see the blood flow in this normal artery is completely open. This is showing it sliced this way. In cross-section, you can see it's kind of completely open. But as you develop this plaque here, right, you can see that you can start getting narrowing of that artery, all right? The more that artery narrows, that can cause problems in terms of your symptoms. This is a picture of a gentleman having angina, okay? That's chest discomfort. And what most of the time happens is when you have partial blockages, people don't have too many symptoms when they're sitting, doing nothing. But when they start exerting themselves, when they start exercising and putting themselves out there, that heart needs more blood flow. It needs more fuel. And that's when those blockages become apparent, because it's like, I can't get enough blood through here because there's some blockages. And that can cause some chest discomfort. Difficulty breathing is another common symptom as people get more active, okay? So that's what we call chest pain or difficulty breathing with exertion, with activity. It can also lead to some dysfunction of the heart as well. Yes?
I have one question about that. So
Absolutely.
when folks say that they went to the cardiologist, they had a echocardiogram done, for instance, the echocardiogram revealed that they had 100% blockage. At what point, symptom-wise, would somebody know or sort of kind of like start to have symptoms by the fact that their coronary arteries are 100% blocked versus some folks who are like 50% blocked or something?
That's a very, very good question. So I'm gonna go to the next slide. I'm gonna answer that question because it's a very good question. Let me just start by saying, because you talked about percentages. So we'll talk about the procedure we use to diagnose coronary artery disease, but 70% usually, well, sorry, in the 50 to 70% range, there's one main artery that's right here called the left main coronary artery. If you're 50% blocked in there, that's when it starts to cause symptoms. And the other arteries, by the time they get to be about 70% blocked, that's when they start to cause symptoms. Okay, start to cause angina and shortness of breath. So that's the beginning. 50 to 70% is when it starts to cause symptoms. Your 100% blockage is a very important question, and let me get to that by starting with this other question of a heart attack. Okay, so heart attacks are the most extreme cases of coronary heart disease. And that's when you have either severe, very severe, or total blockages of those heart arteries, right? So here's the heart artery, and you can see almost no blood able to get through. When that happens, the muscle that comes after that can basically die. You can have death of heart muscle. That's irreversible. And that's called the heart attack or myocardial infarction. Now, that is what happens most of the time if you have a sudden blockage. If all of a sudden you're there and the blockage happens suddenly, and usually what happens is there's plaque, and there's also a blood clot that forms on top of that plaque and can cause that sudden heart attack. Now, there's occasionally, it's not that often, occasionally people have gradual blockages that happen very, very gradually over time. They probably had symptoms at some point, like angina, shortness of breath, the chest pain, shortness of breath, but it happened gradually. It wasn't like a big sudden heart attack. It was a gradual blockage that gets 50%, 60%, 70%, 80%. And what happened is over time, that muscle said, I'm not getting enough blood flow, and it actually caused other blood vessels to say, we gotta give you a little bit more. It's not as good as what you were born with, but we'll give you a little bit of extra blood flow called collaterals.
Yes.
The point is that those people have that, and they have, over time, get all the way to 100% blocked, and get a little bit of blood flow from those collateral arteries, and it's a little bit different than these heart attacks. That collateral is not as good as what you're born with. They may still have symptoms, but it's not the same as a heart attack. So that doesn't happen very commonly, but what you're describing happens sometimes. Either way, by the time you get to 50 to 70% block, most people start having symptoms. Does that make sense, everybody? Okay. So, let's talk about the risk factors for coronary heart disease in particular. And you asked about a couple of these things. So, there's two categories of risk factors. One category is the things that you can modify and do stuff about. Another category is the non-modifiable ones. Let's talk about the non-modifiable ones. As much as we'd like to, none of us can modify our age. It just is what it is, right? So that's what it is. But I will say, actually, there's a very important concept. Age, there's an old song, age is nothing but a number, and that's a chronological age. That's what, your year born. But there's a different thing of what your vascular age is, what the age of your blood vessels is. And what you do with these other things actually dictates what the age of your blood vessels is. So that's a very different concept. So you can't do this, but you can do the other one. Male gender, as I said, men at any given age have more heart attacks than women. However, because women live longer, especially as they get older, they end up having a predominance of the heart attacks there. And then the family history of early heart disease. You can't specifically modify that. However, by seeing a specialist and trying to determine what it is that led to your early heart disease history, those individuals can actually reduce their risk overall.
I have one question about
Yep.
that, about the non-modifiable risk factors.
Mhm.
So since we just saw a couple of slides back that heart disease can happen to both men and women at similar rates, then why not just say gender instead of specifically saying male gender, because it could almost be feeling like sort of exclusionary, but it's really
Yeah.
not.
Well, the only reason that's important is there's two things that are important lessons, I think, when you're talking to patients. So number one is for everybody to understand that regardless of whether you're men or women, that heart disease is the leading cause of death. So people should be aware of that and focusing on their controlling the risk factors regardless. However, it's also important that if you're a 50-year-old who comes in and has symptoms or has stuff, you're more likely, if you're a man, to be the one having a heart attack at that age.
Okay.
So there is a lot of data saying that if they were living the same age, the men were having more heart attacks. But because the women are living longer, they're having more as well. It's still the number one cause of death. So male gender is in fact a very strong risk factor, so that's important to be aware of. But it's also important for women not to feel like, well, I'm fine, I'm not gonna have any issues, because they will potentially late in life have that risk as well, okay? Now here are the things that are modifiable risk factors that we can absolutely control. So abnormal cholesterol, as you heard about from Dr. Martin, is a very big risk factor for heart disease. It's actually what makes up those plaques that actually close those arteries up. Smoking is a huge risk factor, and if you're seeing somebody who has heart disease, or somebody who's at risk for heart disease, which is basically everybody, stopping smoking is the number one thing you can do, like more powerful than medications, to knock somebody's risk down, and it happens almost immediately. Within a week, their risk for heart disease goes down substantially. Yes,
Can you
ma'am?
give like a brief tidbit just about how smoking cardiovascular-wise shows up with regards to symptoms? Like some folks might say, well, my hands and feet feel cold oftentimes, or they may have tingling in the hands and feet or something like that.
So the way smoking is causing this problem here, most of the time, is two ways. Number one, smoking actually causes direct damage to the blood vessels themselves, and smoking also makes your platelets abnormal as well, and makes you more likely to clot. So both of those things are big factors for people developing heart attacks and or blockages in the heart arteries. You could also have some other kind of more, so the tingling in the feet and hands, so there's a kind of tingling that happens with heart attacks, that you can get some tingling in your left hand. That's because the nerves that go to the heart also go to this region as well, and that can cause people to have, like, ooh, I'm having pain down here and tingling here at the same time as this, and I don't know what's happening. That's because those nerves they get confused because they're doing the same region. They're like, I don't know what's, so that can happen. In other areas, that's less likely to be just because of the heart itself. You can get tingling from a variety of things. Diabetes causes tingling, what we call neuropathy. And then some of the...
circulation.
Yeah, so circulation can be an issue, and that can happen with smoking. That was the last thing I was going to say, that you can get problems with the blood vessels, not just in the heart, but in the legs and in the arms as a result of all these factors as well. And smoking is a big one for that. And it can also sometimes cause a little bit of, it can make you predispose a little bit of that kind of spasm, which causes those kind of coldness and tingling that you're talking about. So smoking causes a whole bunch of problems. And the big thing is that it can get better really quickly if you stop smoking and take advantage of that. So a lot of times, for example, I see people in clinic and in the hospital, and I will throw everything I can at them, because that is one of the biggest things we can do to help them live longer from heart disease. So it's a very important thing. Yes, ma'am?
I have an aunt who is hard-headed. She has had 2 mild heart attacks. She has stent, and she's still determined to smoke. No matter how much I talk to her, she's still determined to smoke. It's almost as she had one of those attitudes, oh, it's not going to happen to me.
Yeah, so, I mean, I think, and it's really hard. It's really hard. For some people, it's a really, really bad addiction. So that's the first thing. But then there's other people who have either one or two problems. Either they feel somewhat invincible, or they don't feel like anything they do is going to make a difference. And both those things aren't true. The smoking will definitely make, if somebody who has heart disease smokes, you're going to die much earlier. There's no question about that. On the other hand, though, if you stop, we know from laboratory data, all kinds of data, that those people get better almost immediately. You start seeing improvements in their platelets, and over time, their risk goes down to almost the level of somebody who didn't smoke. So you can actually make a really big difference, but I think, don't stop, because you never know. I've had sometimes people in their much older age who decide to stop at some point. Other things, high blood pressure, obviously, which is what we're focusing on here, is a big risk factor. I'm putting these all together: diabetes, obesity, and something called the metabolic syndrome. Basically, all things that basically relate to abnormal processed extra fat and abnormal processing of sugars are all big risk factors. And then being sedentary, not doing anything, not exercising regularly, is also a very big risk factor for this as well. And diet, I didn't put in here directly, but I'm going to talk about that in a second. Yes, ma'am.
This is a clarifying question.
Yes.
Modifiable male gender or sex? Similar sex?
I tend to use those interchangeably, but there may be some that are more sensitive to me than that. But I'm saying
Depending on the context.
yeah, it depends on the context. But I'm just speaking of. I'm talking about biologically being of male gender or male sex specifically, and that's where there's a bunch. Nobody knows exactly why. Some of it people think has to do with menopause, and that's when the risk actually starts to go up significantly for women. There's a whole other discussion, so we don't get into that too detail. But I'm just saying that it happens after that is what I'm saying. But either way, there's definitely an early higher risk for male gender.
I don't know if she's hinting it too because of the fact that there are folks who are like transgender.
Yeah, that's what I'm saying. So that's why I'm saying male gender by itself is a significant risk. In terms of identifying as male sex, that's not by itself associated with the risk. However, some of the medications that are used to make that transformation can sometimes be associated with increased risk. So testosterone in certain forms can have some challenges associated with it. But I'm talking specifically about biological sex at birth. Okay. So let's talk about risk factor management and prevention. And the reason we're going to talk about that is because that directly influences both your risk of developing heart disease and also your risk of repeat events if you already have heart disease, okay? And because of that, there's two types of prevention. So there's something we call primary prevention. Primary prevention is basically, hey, you don't have, I don't have heart disease. That's fine. But by controlling your risk factors, we're going to prevent you from developing any heart disease in the first place. That's called primary prevention. We don't want it to happen. An ounce of prevention is worth a pound of cure, that whole thing. We're going to prevent it. So that's primary. Secondary prevention is basically people who have existing heart disease. We're like, look, we're going to treat you and also make sure all these risk factors that we just talked about, we can modify, are as good as they can be to avoid recurrent heart disease events. So you had a heart attack before, it's even more powerful if you have another heart attack, because then you had a heart muscle that's already damaged, you damage more heart muscle. We want to prevent you from having death, we want to make you be able to do things. All those things are why we do secondary prevention. So there's primary and secondary, but both are very important. Yes, ma'am.
Okay, as far as the primary prevention, when you start getting older, you tell me how old I am, but when you start getting older, you go to the doctor, they tell you start taking aspirin.
Okay.
Mm-hmm.
Let's get back to that a little bit.
Okay.
I'm gonna go through aspirin and other stuff in just a little bit. Important question though. So here's the second thing. So risk factors are often evaluated together. So we just talked about all those individual risk factors, but what we often do is we add them up and say, hey, what's your overall risk of developing a heart attack over the next, for example, 10 years? And that's basically putting together a risk score. So this is a link to a website that we often use to do what's called the risk estimation of people's risk for heart disease. That's part of why we do, so Dr. Martin may have mentioned this because it's one of the things we use to say who just needs to get a statin medication, for example, is based on what the overall risk score is. So let me just show you this particular site. This is an example of, this is actually just taken directly from that site here, okay? And basically you input what your gender is, what your age is, what your cholesterol level is, your good cholesterol, which is the HDL cholesterol, what your total cholesterol is. Are you being treated for hypertension? Do you have a history of diabetes? What's your race? Because they basically have different scores for white or African American or other race. What's your actual systolic blood pressure? And are you a smoker? And based on that, it'll basically give you a number that says, here's your overall risk of developing a heart attack over the next 10 years, okay?
And then once you, for two questions about this.
Yes.
What would sort of make you, based off of the patient's like history,
Mhm.
you want to perform this risk calculator, one, and
Yeah,
then
so-
two,
sorry,
what kind of, what would you then do with this information once you get the
Yeah,
report back?
so we as cardiologists often use this risk calculator for two reasons. The first reason that's most relevant to you is to be able to tell somebody what their risk is for actual heart disease. So, you know, and the risk can change based on certain things, right? So let's say somebody's has a systolic blood pressure of 180, but they want to get the systolic blood pressure down to a normal level like 120. You can calculate the risk level at 180 and also at 120 and see the difference. Let's say somebody's cholesterol is up in the, you know, high 200s, but they should be closer to less than 200. You can kind of calculate it based on that as well. Let's say somebody's smoking, but then they want to be motivated to stop smoking. You want to say what the difference is. So you can actually use it as a tool for that. The other thing that actually comes out from this is not just your risk over the next 10 years, but something else called your lifetime risk of heart disease. So your lifetime risk actually very much depends on what your risk factor profile is. So the lifetime risk, it actually starts with people who are, I think, at age 40, but it'll give you that as well. Basically says, if all your risk factors, so I'll just give you an example. If all your risk factors are in what we call optimal control, in a good place by middle age, those people have a risk of developing heart disease over their lifetime of less than 5%.
Okay.
On the other hand, people who have multiple uncontrolled risk factors, like 2 or 3 highly uncontrolled risk factors, have a risk that's closer to 50%. A very, very big difference over the course of their lifetime depending on that. So especially with people who are a bit younger and don't have heart disease, it can actually be an important motivating tool for saying, hey, if you actually optimize your risk factors and get them where they're supposed to be, we can make a really big difference on what happens for you across your lifetime. You may not be at a very high risk for heart disease right now, like tomorrow, but we know that in your lifetime it's the #1 cause of death, and that doing these things and getting them better can make a difference. So most of the time, from your purpose, is going to be for education and understanding. And understanding also, when Dr. Martin talked about the cholesterol, which people should be on statin medications, because some people with high risk scores should be on that. As a cardiologist, we also use it. There's certain medications we give to people based on what their risk score is as well. And that's a little bit more kind of for the specialists, I would say. Okay? But that's where that's a little bit helpful. And often people who have risk scores of greater than 20% are considered pretty high risk, okay, overall, in terms of over the next 10 years. So, what are the so now let's talk about some common symptoms of heart disease, okay? And the symptoms of heart disease depend on the type of heart disease, okay? So we talked about angina, right? And what was angina again?
Chest pain.
Good, chest discomfort, excellent. And that is often the sign of poor blood flow to the heart muscle, okay? So that's what we think about when we think about coronary heart disease especially, okay? Dyspnea is another thing that's called shortness of breath, okay? Like I just ran a race, right? And dyspnea can come with a few types of heart disease. So it can come with coronary heart disease, as we talked about. If you don't have good blood flow to the heart, that can cause that. Congestive heart failure, where the heart's not pumping or relaxing normally. If you have blood that starts to build up and instead of going forward, starts to back up into the lungs,
Yes.
you can get shortness of breath from that. It's actually probably the most common symptom from congestive heart failure. Valve disease, if the valve is too stiff or too leaky, can also cause that. And certain kinds of abnormal heart rhythms, when the heart's going too fast, not giving enough time for the heart to fill up with blood, can also cause shortness of breath. So dyspnea is, for better or worse, is not a very specific symptom because there's many types of heart disease that can be related to that. Palpitations, you talked about PVCs, for example. Palpitations are often a sensation. So it's basically people what they feel. Do you feel that your heartbeat is really strong or irregular? Right? Does it feel like it's either thumping like it shouldn't be, or feel like it's like doing something like skipping a beat or doing a bunch of extra beats or going really fast? All those things are palpitations. So a sensation of a strong or irregular heartbeat, and most of the time that relates to arrhythmias, abnormal heart rhythms, okay? And then I would say edema. So edema is, when I was in medical school the first year, I kept calling this edema. I didn't know, but it's edema. So edema is swelling, and it's most often in the legs, okay? People often often they also will use some images of the heart muscle as well. Either they'll use something called a nuclear test to see if there's problems with blood flow not going places when you're stressed, or an echocardiogram to see if the heart starts not moving very well when you get under stress. So those are two things that we do to also help with giving us a better sense of diagnosis in this. Also, there's some patients who can't walk. They're like, I got bad arthritis, or I have whatever, I can't move very well. So there's ways to do it with a treadmill. There's also ways to just do it with medicine. So it acts like you're exercising, basically. So there's many different forms of stress tests. But the point of all of those is to see if there's evidence of coronary heart disease that you will see under stress. Does that all make sense? Okay, all right. Now, let's say you're like, man, I'm even more concerned. I'm concerned this person has a heart attack or coronary artery disease. There's even more advanced tests like cardiac catheterization, okay? Cardiac catheterization, that's where you see the 100% blockage, okay? I'm not gonna go over this in detail, but I just wanna show you what it is. Basically, the idea is to take a direct look at those coronary arteries. So you either put a catheter in the artery in the leg or in an artery in the arm. All of those are connected to that aorta, that main artery that comes off the heart where the vessels come off of. So you place that catheter, take it up to the coronary arteries, and then you inject dye into those coronary arteries, and then here, you see that area where the dye is not going, that very narrow area? That's a significant blockage. That's probably about 90 to 95% blocked in that coronary artery. And that's the way, so the stress test can give you a clue. If you need to confirm it, this is the way to directly visualize it. Or if somebody's having a heart attack, this is often the test we'll do immediately to see, is there definitely a blockage going on, because you want to give that person treatment, okay? So that's what you do with a cardiac catheterization. So let's talk about treatments, and we'll talk about treatments for that very severe blockage as well. But there's important things that you have to think about for people who have heart disease. So we've talked about some of these as we were talking earlier. So number one, what do you understand about the heart disease, right? Having an understanding of heart disease is everything. Because if you don't understand it, you won't know why you're taking medications, you won't know how it's important to take them, you won't know what things you're supposed to be doing in terms of making lifestyle changes, and you won't understand that you can make a difference. So understanding your heart disease, understanding why you're getting certain recommended treatments, understanding the benefits of taking these different medicines or adhering to treatments, and also what are the risks if you don't do it. Then everybody's different. So one size often does not fit all for things like thinking about people with heart disease. So some things have maybe not worked in the past for somebody, or what's currently working. You want to understand that so you can understand what's helpful. But a big issue, I think is going to be something you guys are going to be paying a lot of attention to, are what are the barriers that are making somebody not actually adhere to the medications that are actually being recommended? Is it questions about cost? Is it questions about understanding? Is it other issues or concerns or a lack of trust? So these things are all very important. And you want to really address concerns and questions for individuals to make sure that they have the best plan for managing their heart disease and their risk factors possible, okay? So I think I'm going to go over a couple of the treatments that are proven, which depend on the kind of heart disease. And it's important to realize that you don't need to know all the different treatments. Usually this is done in conjunction with a cardiologist. It should be for anybody with heart disease. So treatment for coronary heart disease, here are the 5 things, the 6 things that are the big things to think about. And I'm going to give it to you in a format that we often use, which is called the ABCs of treating heart disease, okay? A stands for antiplatelet agents. So those are things that basically prevent platelets from clotting in the heart arteries. So aspirin is basically what you just asked about, is usually given people who have heart disease or people who are at a very high risk for heart disease, usually based on that risk score that we talked about. So either if you're at an advanced age or have a high risk score or have a prior heart disease, aspirin. Clopidogrel or Plavix is often given to people who've had stents in the past. That the combination of those two together are given to prevent the stents from blocking up as well.
What medicine did you just say?
Aspirin and clopidogrel or Plavix. Okay. B is for blood pressure control. We usually say blood pressure should be less than 140/90. There's a lot of different options for this, but the common ones are ACE inhibitors, beta blockers if you have heart disease as well. Those are kind of common categories, but there's other ones for treating blood pressure overall, which I'm sure you're hearing about. Cholesterol management is key for that. So we like to get people's cholesterol nice and low, usually with the statin medications for people who have heart disease. Cigarette smoking is the other C for getting people's cigarette smoking, as I mentioned, is one of the biggest things we can do to reduce the risk for heart disease mortality. Diabetes control is very important, and then exercise, diet, and weight management, all of those together make a huge impact on basically people's well-being and also the risk of having future heart disease events, okay? So all those things are kind of part of what we think about for people with heart disease. Now, if you have somebody who has symptoms that even while they're with a cardiologist, and they have symptoms that are not stable, you know, they're having worsening symptoms, they're getting chest pain more and more easily, they're having chest pain with doing very little, you're concerned about a heart attack, sometimes we actually, besides just those medicines and those risk factors, need to improve blood flow to the heart. And that's where we need to do things like stenting. So this here is an example of having a plaque. The stent is a small mesh wire tube that you put in the artery. It gets blown up by a balloon, and then that stent becomes a part of the blood vessel wall, okay? And basically, your blood flow gets normal again. So that's sometimes what has to happen. People have very bad blockages and symptoms that don't get better, or they're having a heart attack with medical treatment. Sometimes we actually even have to consider surgery. And have any of you heard of bypass surgery? Okay. So the idea of bypass surgery is that you have a lot of different blockages. So here's a blockage in this main artery you're born with, another blockage in the artery. And instead of trying to go through multiple blockages with a bunch of stents, you actually bypass them by taking, this here is a vein from the leg that goes from an area with good blood flow in the aorta and goes past the blockage. And there's an artery that you take good blood flow and go past the blockage. So it's bypassing where those blockages are, like a detour of blood around those areas. So that's another thing that sometimes happens for people who have very severe or progressive symptoms, okay? Heart failure, we talked about, that can be due to poor pumping or poor relaxation of the heart, okay? I'm not gonna get into this in too much detail, but basically there's a variety of treatments that we think about for the reduced ejection fraction. When the heart's not pumping very well, sometimes, let's say, blockages in the heart arteries are the issue. We sometimes need to treat those. And then there's other classes of medications that are important for this, beta blockers and ACE inhibitors, and this is why, and then other medications that are sometimes important. This is why this is done with a cardiologist together. So anybody who has a condition like this, as I'll talk about in a couple slides, it's important to have people involved. Preserved ejection fraction, most of the time you're going to control their blood pressure and their heart rate to give that heart enough time to fill up with blood, and the blood pressure can make the heart, if it's too high, even more stiff. So that can actually cause problems with that normal ejection fraction. And then, for both of those, who's heard of Lasix? Diuretics? Okay, good. So the diuretics, Lasix, anyone know why they call it Lasix, by the way? They used to give it to racehorses in the last 6 hours. That's why they do it. Last 6, that's how it got started. Anyway, so diuretics, they give that medication to basically take off that extra fluid that's building up and going into the heart, into the lungs. And you often have to tell people to watch how much sodium they're taking in, watch how much fluid they're taking in, and then to watch their daily weights as well. Okay. And that tells you basically whether or not they're building up fluid. And then self-management. So that's also very important. So here's some of the big things. So number one, adhering to your medications. Okay, things that are helpful for that are things like pill boxes, making sure people know what they're supposed to be taking with a schedule, supporting them with reminders. Heart-healthy diet, so generally we recommend 2 to 3 servings of fruit per day to minimize red meat and fried foods from a cholesterol standpoint. Regular exercise is a very big deal, and what we say is basically 30 to 40 minutes most days of the week. So at least 4 if possible, 5 even better, and even walking counts. So you don't have to go to the big gym and get all dressed up. Even doing some good brisk walking makes a difference. And then weight loss, losing just 5% of the body weight basically has an important impact on all the different risk factors we talked about. So that is often a goal for people who are overweight, just 5% of their body weight. You get more benefit with more, but at least 5%. The frequency of follow-up is for people with, most of the time with heart disease. So this is more of my guidelines. If I have people who are very severe or unstable heart disease, I'm often seeing them at least every 2 or 3 months, sometimes in a few weeks, just to make sure things are stable. But a cardiologist should generally be involved in these cases. If they're high risk, you know, have a bunch of blockages or having a very, very bad arrhythmias, but they're stable, there's high risk, I'll follow them every 4 to 6 months. And then they're very routine, low risk and stable, every year should be okay in terms of follow-up time. So, when do you want to refer patients to a cardiologist? So this is obviously important to this project in particular. So here are some of the things, I think they're in your, it'll be in your protocol. So they have known or suspected heart disease and they're not actually being cared for by a cardiologist. If you have concern, they have unstable coronary heart disease. So they're having new chest pain, increasing chest pain. They have ECG changes that you're worried about. They're on medical therapy, but their symptoms they're really having a lot of symptoms. Those are people who should be seeing a doctor. Congestive heart failure that is unstable or is decompensated. So basically people who are having a lot of shortness of breath without doing very much or at rest. There's something called paroxysmal nocturnal dyspnea where you wake up at night because of your heart failure with difficulty breathing. That's also important as well. Or worsening symptoms. Palpitations that are just increased or not controlled, that you worry about an unstable arrhythmia, they should see somebody. If they previously were stable, they're like, I'm fine. Only when I go up that hill at the end of my 20-minute walk, I get a little bit of chest pain. But then all of a sudden, they're like, well, now at home, every time I go up the stairs, I'm getting chest pain. Walk from room to room, I get chest pain. Those are unstable symptoms, or other unstable cardiac symptoms that were previously stable should make you see a heart doctor. And then that 20% mark I talked about. If you're at high risk for developing heart disease, those are people who usually it'd be beneficial for them to see a cardiologist to make sure they're part of their management, okay? So, finally, supporting patients in maintaining their behavior change. So I think that there's a few things that I find in my clinical work very important for supporting patients, and hopefully it matter for you. So I think it's very important that people have a clear understanding of the condition. So, and one thing that's really important is I see a lot of patients who walk out of the doctor's office and afterwards they're like, I don't know what was just said. And they ignore everything because they don't have a basic understanding. So making sure you're saying it in language they can understand and making sure you're answering their questions and being as clear as possible is helpful. Making sure there has a trust in the relationship, I think, is huge. If people don't trust you and don't feel like, we're partners, then I think it's very hard to get people to really believe in these different things that you're trying to tell them about. Agreeing on treatment goals, not just saying, hey, you're going to do this, you're going to do this, you're going to do this, but actually being on the same page and having a shared plan for a treatment goal is, I think, is very important. And this is very important. How important is the self-management? Not just that, hey, we're saying do these different things, but the more you do these things, the better you're going to do. And people believing that what they do can make a big impact in their outcomes is very important. If people have barriers to adherence, working with them and problem solving to help them solve those is very important. And then, this is heart failure, heart disease, just emphasizing how much we can modify their heart disease risk overall. And here's a big thing. People have a lot going on in life, and it's often hard for them to prioritize themselves and their wellness. But I try to give people permission to make sure that they, in addition to everything that's going on, focus on their heart wellness, their cardiovascular wellness among their life priorities. Like building time into their day to take care of themselves and their bodies. Okay, we only have a couple minutes, so this was a quick case, so I'll see if you guys can give me your thoughts about this really quickly. A 55-year-old lady who has known coronary heart disease has been followed by a cardiologist. Her blood pressure is 144/96, her weight's 195 pounds, her BMI, that's a measure of weight, so body mass index greater than 30 is obese, and she's 36. She's missed her last couple appointments with a cardiologist. Her labs haven't been checked for a while. Her dad had heart disease at an early age, and she's pretty discouraged because she really doesn't think there's anything she can do about her heart disease because of this family history of heart disease. So how do you approach her, and what things you might recommend for her if you're seeing something like this? This is not uncommon at all. What are your thoughts? You all know people like this. You've actually even mentioned, as we've been talking about, folks who are doing things that they're not supposed to do, who are feeling some way, who also have, don't know that they can actually change things. They have a family history. So what are your thoughts?
That's what I was going to say, because her father passed with heart disease doesn't mean that she has to, because she can do a lot of things to sustain her life. Absolutely. And not die at an early age. So she's probably feeling a little depressed because she feels as though there's nothing she can do because it's hereditary.
Absolutely, absolutely. I was seeing a guy in clinic the other day. I can't talk about too many things because of HIPAA, but everybody in his family has had heart disease deaths at the age of 40s and 50s. But he determined early on he was going to see a cardiologist. We've been together for quite some time. He's now 70. He's doing beautifully. His heart disease, he's doing beautifully. And I suspect he's going to live for quite a long time. And every time we meet, we talk about the fact that how different what's going on with him is versus family members. He wants to get them in, but he realizes that he can make such a difference in his life by taking care of things, even with his family history. So having people believe that is really, really important. Having them buy into that and be motivated for that is important. Do you see things here we could change?
The BMI.
Yeah, her weight being high, risk for diabetes, the high blood pressure, we better control weight being lower. You see the blood pressure is high as well.
And the diet will help with the blood pressure.
Absolutely. She hasn't had her labs checked, so we don't even know what her cholesterol is, and we know we want to have that really low for somebody who has a like coronary heart disease. She's not seeing a cardiologist, so we haven't had any.
Might be a barrier for why she hasn't gone to her appointment.
Exactly. So we want to understand that. What is it? Is it because you're feeling depressed about what you can do? Is it because there's other issues that are barriers? So what we want to do is kind of approach her situation, help her believe and understand that she can make a difference, that she can change things, that what happened in the past doesn't have to be her situation. Show her how much we can change, and then start helping her solve if there's barriers or challenges to make sure that we can actually get there. So I think all the things you guys have mentioned are very, very true. So here are some resources. On this age, American Heart Association website, this is actually particularly for caregivers. So if you go to this here, it gives you educational stuff. It'll give you tips for helping people with their lifestyle changes or adhering to medications. So this is a really nice site. This is the Chiadi Center's area that gives some information about healthy hearts and prevention and risk factor control. And then that risk estimator I showed you earlier for looking at the risk score, we're getting the 10-year risk and the lifetime risk. That's right here in this web page as well. So just to summarize, so heart disease has several different forms. It's the leading cause of death in the United States. It can be prevented, and it can be managed with risk factor control. As I mentioned, if you have normal risk factors by middle age, 5%, less than 5% rate of developing heart disease over your lifetime. So risk factor control makes a big difference, even if you don't have heart disease yet. There's a lot of proven strategies, each of which depend on the type of heart disease. And as I mentioned, a cardiologist should be involved for people who have heart disease. But it's also important to help people feel empowered, that self-management is the key to determining their outcomes, and that it's important to support patients through a trusting partnership in actually addressing both barriers, addressing challenges, and making sure that they're actually meeting all the goals for helping them with their heart disease. Okay? I think we've talked a lot during. I think I'm out of time in terms of questions, right? 2:30 right now.
Yeah, you are out of time.
Okay.
But
So,
a lot of people ask questions
Yeah.
about the presentation.
yeah.
so-
Are there any really burning ones that I can answer quickly?